Hello everyone, today we'll discuss ischemic heart disease briefly. We'll see the introductory part, we'll see the underlying pathophysiology, different clinical types, and finally we'll summarize. So what is ischemic heart disease? Ischemic heart disease refers to myocardial injury due to occlusion of coronary arteries resulting in myocardial oxygen supply demand mismatch. So this is mainly from coronary artery atherosclerosis resulting from build-up of atheromas within the vascular lumen, which results in narrowing and progressive decrease in blood supply. So the heart cannot meet its metabolic limits. So to really understand the pathophysiology, first let's understand what ischemia and infarction and their differences. Ischemia is due to reversible cellular injury, and infarction is due to irreversible injury. So ischemia results in cellular swelling and decreased contractility. Infarction results from membrane rupture, which results in release of intracellular proteins. So this one is reversible if the blood flow is restored within 20 minutes, and infarction is due to prolonged ischemia, which results in myocardial necrosis. So ischemia explains the patterns we see in stable and unstable angina, in which there will be no rise in troponins. However, in infarction, due to myocardial cell membrane damage, there will be release of troponins, and this explains NSD and LSD. So how does patients present clinically? They present with typical type of anginal chest pain, which is a retrosternal chest pain characterized pressure or squeezing type of pain. Patients typically present as some heavy thing standing on their chest or belt tightened around their chest. So this pain radiates to the adjacent areas such as the left arm, the neck, and the jaw, and is typically triggered by exertion or psychological stress, and is relieved by either rest or nitrate sleep. So how does we differentiate from different types of chest pains, such as GI or respiratory causes? It's not affected by the body position or respiration, and there is no chest wall tenderness. So there are other associated symptoms such as gastrointestinal discomfort, dizziness, palpitation, and autonomic symptoms such as diaphoresis and syndrome. Particularly, these atypical symptoms are common in patients such as elderly women, diabetic patients, and patients with autonomic neuropathy. So there are two major mechanisms, as we have seen in the first slide. This is either due to fixed obstruction resulting in stable angina or acute coronary syndrome based on acute plaque rupture and thrombosis of the vascular lumen. So acute coronary syndrome can be further classified as unstable angina or myocardial infarction, and we will see the details in the subsequent slides. So the key difference here is the degree of occlusion and the degree of myocardial damage, and they are differentiated based on the characteristics of the vein, the ECG findings, and the troponin cardiac biomarkers. So let's see the first one, stable angina. So stable angina is a predictable type of chest pain resulting from fixed narrowing of the coronary vessels, and at least around 70% of the lumen should be occluded to cause symptoms. So the pain is triggered by exertion, and it's relieved by rest or nitroglycerin, and on ECG is typically normal unless the patient is symptomatic during evaluation. And this ischemia and the troponins are normal, ECG is normal. So unstable angina is due to plaque rupture, but still there is some blood flow, and it's non-occlusive thrombus. So the pain, how does we differentiate from stable angina? It occurs at rest, or if the patient has stable angina, this is a type of a new worsening type of pain, more severe and more frequent type of pain. So on ECG, patients might have a steady depression or T-wave inversion, and troponins are normal as it is clear. And STEMI, this is still due to plaque rupture resulting in partial occlusion. There is still some blood flow, but this one is more worse, and it results in infarction, some endocardial infarction, as you can see in the picture. So it results in ST depression and T-wave inversion on ECG, and the troponins are elevated sensitivities and infarction. So the fourth one is STEMI, which is due to complete coronary occlusion. So there is no blood flow at all. There is no blood flow here. and it results in a transmural type of infarction. That means the whole thickness of the myocardium is infarcted. This results in ST elevated MI on ECG, and the troponins are elevated, or this requires immediate reperfusion. So in summary, so based on the degree of occlusion, as you can see here, the complete occlusion results in STEMI, the partial occlusions due to plaque rupture results in a stable angina and STEMI, and the fixed obstruction results in stable angina. On ECG, stable angina and unstable angina might be normal, or they might present with some STMT wave abnormalities, and STEMI will result in ST wave depression and T wave depression, and STEMI will result in ST elevation uh, and elevated troponins. So thank you for listening.